Hey everyone, today we're diving into the world of sulfa drugs. These were actually the very first antibiotics ever used, and they have a fascinating history.
From dyes to drugs. Back in the 1930s, a scientist named Gerhard de Mack discovered that a dye called Prontosil Red could fight bacterial infections in mice. This was a breakthrough. Soon after, doctors found that sulfanilamide, a component of Prontosil Red, was the real crime fighter against bacteria. Sulfa drugs quickly became wonder drugs. They could treat a wide range of infections, from strep throat to pneumonia. But just like any villain, bacteria eventually figured out how to resist these drugs. By the 1940s, many bacteria had become sulfur-resistant. Chemistry of sulfonamides. All sulfonamides trace their lineage back to sulfanilamide, also known as p-aminobenzene sulfonamide, serving as their foundational compound. This structural similarity underscores their shared mechanism of action and therapeutic effects. However, it's the subtle variations in their chemical structure, particularly in the N1 substitution, that give rise to differences in solubility, potency, and pharmacokinetic properties among sulfonamide derivatives. The N1 substitution plays a pivotal role in determining various pharmacological characteristics of sulfonamides. Alterations at this position can significantly impact the compound's solubility, affecting its absorption and distribution in the body. Additionally, changes in the N1 substitution can modulate the potency of the sulfonamide, influencing its effectiveness against bacterial pathogens. Furthermore, the presence of a free amino group in the para position N4 is essential for the antibacterial activity of sulfonamides. This amino group interacts with bacterial enzymes involved in folate synthesis, disrupting essential metabolic pathways and inhibiting bacterial growth. Thus, the integrity of the amino group at N4 is crucial for the therapeutic efficacy of sulfonamide compounds. Sulfonamides. Mechanism of action. Here's the clever trick behind how sulfa drugs work. They exert their antimicrobial effects by targeting bacterial folate synthesis, an essential metabolic pathway crucial for bacterial growth and replication. Bacteria, unlike humans, must synthesize their own folate vitamin B9, which is essential for the synthesis of DNA, RNA, and proteins. One of the key steps in folate synthesis involves the conversion of p-aminobenzoic acid PABA to dihydropteroic acid by the enzyme dihydropteroate synthase. Sulfonamides structurally resemble PABA, acting as competitive inhibitors of dihydropteroate synthase. By mimicking PABA, sulfonamides bind to the active site of the enzyme, preventing the natural substrate PABA from binding and inhibiting the conversion of PABA to dihydropteroic acid. As a result of sulfonamide binding, the conversion of PABA to dihydropteroic acid is halted, disrupting the bacterial folate synthesis pathway. This interruption leads to a deficiency of folate within the bacterial cell. Folate is essential for the synthesis of nucleic acids, DNA and RNA, and proteins. Inhibition of folate synthesis by sulfonamides deprives bacteria of the necessary precursors for these vital processes, impairing their ability to replicate and grow. By disrupting folate synthesis and inhibiting essential metabolic pathways, sulfonamides exert a bacteriostatic effect, meaning they inhibit bacterial growth rather than directly killing bacteria. However, bactericidal concentrations of sulfonamides can be achieved in certain environments such as urine. Sulfonamides exhibit selective toxicity towards bacteria while sparing human cells. This selectivity arises from differences in folate metabolism between bacteria and humans. Human cells acquire folate from the diet in its preformed state and are not affected by sulfonamides. Overall, sulfonamides are valuable antimicrobial agents that disrupt bacterial folate synthesis, making them effective in treating a wide range of bacterial infections. However, the emergence of bacterial resistance and the availability of alternative antibiotics have somewhat limited their clinical utility in recent years. Sulfonamides, despite their broad-spectrum activity, exhibit varying degrees of effectiveness against different bacterial pathogens. Understanding their spectrum of activity is crucial for appropriate antibiotic selection and treatment planning. Here's a breakdown of the sensitivity patterns observed with sulfonamides against various bacterial pathogens. Streptococcus pyogenes. Sulfonamides demonstrate efficacy against Streptococcus pyogenes, commonly known as Groupa streptococcus. This bacterium is responsible for a range of infections, including strep throat, skin infections, and invasive diseases like necrotizing fasciitis and streptococcal toxic shock syndrome. Haemophilus influenzae. Sulfonamides are effective against Haemophilus influenzae, a bacterium that can cause respiratory tract infections, including pneumonia, bronchitis, and otitis media, as well as invasive diseases like meningitis and septicemia. Haemophilus ducreae. Sulfonamides exhibit sensitivity against Haemophilus ducreae, the causative agent of chancroid, a sexually transmitted infection characterized by genital ulcers. Calamatobacterium granulomatis. Sulfonamides are active against Calamatobacterium granulomatis, the bacterium responsible for granuloma inguinale, a sexually transmitted disease characterized by painless genital ulcers. Vibrio cholerae. Sulfonamides demonstrate efficacy against Vibrio cholerae, the bacterium responsible for cholera, a severe diarrheal disease transmitted through contaminated water and food. Limited sensitivity. Staphylococcus aureus. While some strains of Staphylococcus aureus may show sensitivity to sulfonamides, the majority exhibit resistance. Staphylococcus aureus is a common cause of skin and soft tissue infections, as well as more serious infections like bacteremia and endocarditis. Gonococci and meningococci. Sulfonamides have limited effectiveness against Neisseria gonorrhoeae and Neisseria meningitidis, the causative agents of gonorrhea and meningococcal disease, respectively. Pneumococci. Streptococcus pneumoniae, also known as pneumococcus, may exhibit limited sensitivity to sulfonamides. Pneumococcus is a leading cause of pneumonia, sinusitis, otitis media, and invasive diseases like bacteremia and meningitis. Escherichia coli and Shigella species. While some strains of Escherichia coli and Shigella species may be susceptible to sulfonamides, resistance is commonly observed. These bacteria can cause gastrointestinal infections, including diarrhea and dysentery. Resistant bacteria. Anaerobic bacteria, which thrive in environments devoid of oxygen, are generally not susceptible to sulfonamides. Additionally, despite their historical use against a wide range of bacterial infections, sulfonamides may not be effective against certain pathogens due to widespread resistance. Sensitivity and other pathogens. Certain pathogens, such as Chlamydia trachomatis, Chlamydia lymphogranuloma venereum, Chlamydia inclusion conjunctivitis, actinomyces, nocardia, and toxoplasma, show susceptibility to sulfonamide treatment. This underscores the importance of considering sulfonamides as potential treatment options for infections caused by these organisms. Overall, while sulfonamides remain valuable antimicrobial agents, their efficacy against specific bacterial pathogens may vary, and resistance patterns should be taken into account when prescribing these antibiotics. Sulfonamides are rapidly absorbed from the gastrointestinal tract, with varying extents of plasma protein binding. They distribute widely in the body, readily entering serous cavities and crossing the placenta. Metabolism primarily occurs through acetylation at N4 by non-microsomal acetyltransferase in the liver. Renal excretion is the primary route of elimination, with both glomerular filtration and tubular secretion reabsorption processes involved. Lipid-soluble sulfonamides exhibit prolonged action due to high tubular reabsorption. Despite their therapeutic benefits, sulfonamides can cause adverse effects, including gastrointestinal symptoms, crystalluria, hypersensitivity reactions, hepatitis, and hemolysis. They also pose risks in specific populations, such as newborns susceptible to kernicterus and individuals with glucose 6-phosphate dehydrogenase deficiency. In terms of interactions, sulfonamides can affect the metabolism of drugs like phenytoin, tolbutamide, and warfarin, potentially enhancing their action. Resistance mechanisms typically involve increased production of para-aminobenzoic acid PABA, the precursor in bacterial folate synthesis. B. Reduced affinity of the folate synthase enzyme for sulfonamides. C. Adoption of alternative pathways in folate metabolism. Furthermore, resistance to sulfonamides is a significant challenge in the management of bacterial infections. Various bacterial strains, including Gonococci, Pneumococci, Staphylococcus aureus, Meningococci, Escherichia coli, Shigella, and certain Streptococcus species, have demonstrated the ability to develop resistance to these antimicrobial agents. Despite these challenges,
Sulfonamides remain of clinical interest due to their diverse range of applications and effectiveness against various bacterial infections. Here's a breakdown of sulfonamides that are still used in clinical practice.
1. Short-acting 4-8 hours. Sulfadiazine. Sulfadiazine is rapidly absorbed and excreted, making it suitable for short-term treatment of bacterial infections. It is commonly used in the treatment of urinary tract infections, respiratory tract infections, and meningitis. Its short duration of action necessitates frequent dosing, but allows for rapid therapeutic effects. 2. Intermediate-acting 8-12 hours. Sulfamethoxazole. Sulfamethoxazole exhibits an intermediate duration of action, making it suitable for the treatment of a wide range of bacterial infections. It is often combined with trimethoprim to form cotrimoxazole, a synergistic antibiotic combination used to treat urinary tract infections, respiratory tract infections, and other systemic bacterial infections. 3. Long-acting 7 days. Sulfadoxine, sulfamethoperazine. Sulfadoxine and sulfamethoperazine are ultra-long-acting sulfonamides, with prolonged durations of action lasting up to 7 days. These compounds are primarily used in combination with other medications, such as pyrimethamine, for the treatment of malaria caused by chloroquine-resistant Plasmodium falciparum. They are also used in the treatment of Pneumocystis jirovecii pneumonia in AIDS patients and toxoplasmosis. 4. Special-purpose sulfonamides. Sulfocetamide sodium. Sulfocetamide sodium is a highly soluble compound used topically for the treatment of ocular infections caused by susceptible bacteria and chlamydia. It is well tolerated and achieves high concentrations in the anterior segment and aqueous humor of the eye. Mafenide. Mafenide is a topical sulfonamide used primarily for burn wound care to prevent infection. It exhibits activity against a variety of gram-positive and gram-negative bacteria, including Pseudomonas species. However, its application can cause a burning sensation and severe pain. Silver sulfadiazine. Silver sulfadiazine is a topical sulfonamide cream with broad-spectrum antimicrobial activity, including activity against resistant bacteria such as Pseudomonas species. It is commonly used for preventing infections in burn wounds and chronic ulcers. Sulfasalazine. Sulfasalazine is used primarily in the treatment of inflammatory bowel diseases such as ulcerative colitis and rheumatoid arthritis. It acts as a prodrug, releasing sulfapyridine and 5-aminosalicylic acid 5-ASA in the colon, where they exert anti-inflammatory and antibacterial effects. These sulfonamides continue to play important roles in clinical practice, demonstrating efficacy in the treatment of various bacterial infections, ocular conditions, burns, and inflammatory disorders. Despite the emergence of bacterial resistance and the availability of alternative therapies, sulfonamides remain valuable components of the antimicrobial armamentarium. Key features of sulfonamides include sulfadiazine, rapidly absorbed and excreted, with good penetration into the central nervous system. Commonly used for meningitis. Sulfamethoxazole exhibits intermediate duration of action and is often combined with trimethoprim due to similar half-lives. Sulfadoxine and sulfamethoperazine. Ultra-long-acting compounds used in combination with pyrimethamine for malaria and Pneumocystis jirovecii pneumonia. Sulfocetamide sodium. Employed topically for ocular infections, yielding high concentrations in the anterior segment and aqueous humor. Mafenide. Topical application for burn dressing, effective against a variety of bacteria including Pseudomonas and Clostridia. In conclusion, while sulfonamides may not hold the same prominence in antibiotic therapy as they once did, they still have a role to play in modern medicine. Their ability to team up with other antibiotics and combination therapies, and their use in topical creams for wound and burn care highlight their continued relevance. Despite challenges such as bacterial resistance and adverse effects, sulfonamides remain valuable tools in the arsenal against bacterial infections, malaria, and ocular conditions. As with any medication, the key lies in judicious use and careful consideration of their efficacy and potential risks in individual cases. Thank you for watching. We hope you found this overview of sulfonamides informative and insightful. If you enjoyed this video, don't forget to like, comment, and subscribe for more content. Remember to stay informed and consult with healthcare professionals for any medical concerns or questions. Until next time, take care and stay healthy.